All right. So good evening once again. This is GK Emmanuel, the CEO for GK Consult. So today we are talking about pancreatitis, which is a medical condition. It is a medical condition. So while the class is ongoing, if you have any question, you can just let me know. I would allow you to talk. If you want to ask a question, I would allow you to talk. So that, and then while the lecture is ongoing, I'll pause and then I would ask a few questions so that we move on. So the slide you are seeing, you can all see my slides. I believe so. So what you are seeing is the structure, is the gross anatomy of the pancreas. So you can see the pancreas, you can see the stomach over there, but our main focus is on the pancreas. So yesterday we spoke about a little bit about the pancreas in the surgery. We spoke a little bit about pancreas, and we learned that the pancreas is both what it means is that the pancreas performs the function of both exocrine and then endocrine gland. So the aspect of the exocrine gland, it secretes the pancreatic juice through the pancreatic duct into the small intestine for digestion to take place. And then in the aspect of the endocrine gland, it produces two different hormones, which is the insulin and then the glucagon. So the alpha cells of it produces the glucagons, and then the beta cells of it produces the insulin. And then the cells of the pancreas is called the pancreatic islets. So this is a typical pancreas. It has the body, it has the tail, it has the head, and then it has the pancreatic duct, where the pancreatic juice is secreted through into the how do you call it, the duodenum. That's the first portion of the small intestine. So this is another image of the pancreas. So we said the pancreas is a flattened organ which lies in the abdomen, and it lies posteriorly and slightly inferior to the stomach. So if you look at the position of the pancreas very well over here, you can realize that it lies at the back of the stomach. So posteriorly to the stomach and slightly inferior. So it's just like the back down of it. That's so it is a composite gland. When you say something is composite, it's a combination of more things. Okay, so it's a composite gland and acts as both exocrine and endocrine. So because of its composite nature, it can perform the function of both exocrine gland and endocrine gland. And histologically, it consists of islets, the islets of Langerhans, and then the acini cells. So that's what we call it, the pancreatic islets. That's the islet of Langerhans. So that is the cells. So the cells of the pancreas is called the pancreatic islet or the islet of Langerhans. And then those cells are grouped. They are grouped into portions. So the group of the pancreatic islets are called the acini cells. So let's look at some functions of the pancreas. So the pancreas, it produces pancreatic juice. Yes. It also secretes hormones that regulate blood sugar levels. That is the glucagons and then the insulin. Then it also produces sodium bicarbonate to control the acid base or the pH of the blood. It also neutralizes acid chyme. The chyme is whatever product that is being channeled from the stomach through the pyloric sphincter to the small intestine. So whatever you see, if you eat food and then the stomach digests the food, or the stomach, the atrium of the stomach, the antrum of the stomach grinds the food. The food is called chyme and it's very acidic because of the acidic nature of the stomach. So this food is being pushed through the pyloric sphincter to the small intestine, and it's very acidic. So it is the function of the pancreatic juice secreted by the pancreas to neutralize this acid kind so that it will be suitable, because the lumen of the small intestine is more of basic. So it has to neutralize it to become base for absorption or continuation of digestion to take place. And it also produces the enzymes like the pancreatic amylase, which will further convert different enzymes in the small intestine. So that's it. The pancreatic amylase. So it also, its function is what? It aids in the digestion of carbohydrate. That is, it produces pancreatic amylase to what? To further digest carbohydrates in the small intestine. And then it also produces pancreatic lipase, which what? Will digest lipids in the small intestines. And then it also produces trypsin and then chymotrypsin, which what? Which helps to digest proteins in the small intestines. So these are the some functions of the pancreas. So you should know that if your pancreas is being distorted or impaired, depending on the level or the degree of impairment, you'll be having problems with the functions of these things. So pancreatitis, we have acute and we have chronic. When you say a condition is acute, by this time you should know the difference between an acute disease condition and a chronic disease condition. When we say a disease condition is acute, it means that the onset is very rapid. It comes very fast, or it happens very fast. That's the onset is very rapid. And then the duration is very short. It comes and goes within a short possible time. That is an acute disease. And then the level of deterioration of organ is limited. That is, in an acute disease condition, organs are not deteriorated. It can be reversed. But for chronic, the onset is very slow. So a chronic disease would be very slow. So it will start slowly, progressively. So the onset is very slow and progressively. And then the duration is very long. Sometimes a chronic condition can be with you for the rest of your life, for years, for months, and all that. But for acute, it happens in a days or weeks, and it will just resolve itself. And then for chronic disease too, the level of deterioration is very huge. Okay, all right. And then so we have acute pancreatitis, and then we have the chronic pancreatitis. Acute pancreatitis, and then we have the chronic pancreatitis. So when you say pancreatitis, it simply means the inflammation of the pancreas. Inflammation of the pancreas. So let's talk about acute pancreatitis. It is the inflammation of the pancreas, and it is a serious disorder that can range in severity from a relatively mild. Is that okay? And it's self-limiting as compared to the chronic. So you just describe the acute pancreatitis with the characteristics of acute disease conditions. So acute pancreatitis, the onset is very slow, and then the level of deterioration of the pancreas is limited, and it can resolve as time goes on, and it doesn't stay long. And then acute pancreatitis is commonly described as an autodigestion of the pancreas. Is that okay? By the exocrine enzymes it produces, primarily the trypsin. So we will look at the pathophysiology of pancreatitis, and then you would know that you know how pancreatitis occurs. So 80% of patients with acute pancreatitis have biliary tract disease. Is that when you say the biliary tract disease, it's also a group of conditions that we have. When you say the biliary tree, we have biliary tree. Biliary tree comprises of the liver, the gallbladder, and then the bile duct, and then the pancreas itself. So it looks like a tree. It looks like a tree. So the bile duct, or the common bile duct, is actually the common hepatic duct is actually looks like the stem of the tree, and then the liver, the gallbladder, then the pancreas looks like the leaves and then the branches of the tree. So it looks like a tree. That's why we call it the bile tree. So the biliary tract is the gallbladder, the tract in which the bile passes through. That's the biliary tract. So if there is a disease, any disease at all, it being cholangitis, it being cholecystitis and all that, cholangitis, whatever, that is biliary tract disease. So mostly people that have pancreatitis, they already have history of biliary tract disease. Is that okay? And then sometimes too, they have a history of long-term alcohol abuse. You know, alcohol has effect on the liver and its nearby organs like the gallbladder and then the pancreas. That is why diabetic patients, I advise them not to take in alcohol. Acute pancreatitis, okay, this one I think I've explained it. So pancreatitis occasionally developing as a complication of MAMP virus. So mostly the MAMP virus. So we all know MAMP. That's the disease of the parotid gland. The parotid gland is a type of the salivary gland. Okay, so if there is a disease condition of it, which is called the MAMPs, which mostly affect males, then we should start suspecting pancreatitis. So many disease process and conditions have been associated with an increased incidence of pancreatitis. So if a patient has a history of MAMP, or those patients who are having pancreatitis or who are diagnosed with pancreatitis, mostly they have history of MAMP or they have MAMP virus in their circulatory blood. And then sometimes to people who have had surgery, okay, people who have had surgery too, they are likely, especially laparotomy surgery. Mostly, one complication is damage to the nearby organs, it being the pancreas, the stomach, or the organs. Maybe mistakenly, the surgeon would mistakenly prick or cause an inflammation on one of the organs. And then also some medications too has like steroids. Some medications like steroids, they have effect on the pancreas, so you're likely to get pancreatitis, and sometimes to hypercalcemia. So how hypercalcemia would mix with cholesterol. Is that okay? Hypercalcemia would mix. So these are some of the predisposing factors. So one, predisposing factors. One, we have people who have undergone abdominal surgery, like laparotomy. Two, we have alcohol use. That's high alcohol consumption. And we have certain medications like steroids. And we have people with history of MAMP virus. And then we have hypercalcemia. That's high calcium levels. Now, if there are high calcium levels in you, they will mix up with the cholesterol. And then they will form what we call cholesterol stones. Is that okay? So they will lead to calcification. It will become stiff. And then patients who have high cholesterol level, that's hyperlipidemia, high lipid levels in the blood. So all patients with all these factors are at risk of getting pancreatitis. However, these risk factors actually contribute to 90% of the causes of pancreatitis. But then 10% of pancreatitis cases are idiopathic. When we say a condition is idiopathic, it means it doesn't have a cause. If we say a condition is idiopathic, it means it doesn't have a cause. And there is a small incidence of hereditary pancreatitis. That one, it doesn't really happen. But then there can be a case that your family, people are suffering from pancreatitis and automatically it is happening to you. And few of it too is autoimmune. Few of it too is autoimmune. Is that okay? Whereby the antibodies of the pancreas will start seeing the cells of the pancreas as antigens and it will start ingesting them. Let's look at some clinical manifestations or signs and symptoms of pancreatitis. So if the patient is having pancreatitis, there will be severe abdominal pain. Severe abdominal pain. Now, let me inform you people of this. If you are on the ward, whether you are working already or you are about to start working as a nurse or as a certified nurse, if you're on the ward and then the patient comes to the ward with a history of pancreatitis, with a history of abdominal pain or with a complaint of abdominal pain, please Do not give a painkiller. Do not give a what? A painkiller. It is always not a good idea to give a painkiller when your patient complains of acute abdominal pain, but rather you have to assess. You have to assess for the pain. You have to perform physical assessment. That is why you learn physical assessment. So you have to assess for pain, tenderness. You have to localize where exactly is the patient feeling the pain. You have to conduct your diagnostic investigation before you give the painkiller, because if you go ahead to give, so mostly on the ward, patients will come complaining of abdominal pain, then we will go ahead to give them buscopan or hyoscine bromide or any sometimes we give omeprazole without you not knowing the exact or the right cause of the abdominal pain. For what you know, there is something or one of the organs is being damaged, or there is a damage happening somewhere in the abdomen, and then you've given the painkiller to subside the pain. So initially the patient won't feel the pain, thinking that everything is okay, but everything is not okay, but rather deterioration is happening. By the time you realize whatever has to happen has happened. A case happened like that in one of the hospitals, which I won't mention the name. 11-year-old girl was brought to the facility with abdominal pain, severe abdominal pain. It was very severe to the extent that the girl couldn't walk. So the nurses on duty just gave buscopan, and then the patient's abdominal pain subsided. So the patient was okay. And then the next day, the patient was discharged because the abdominal pain they think it has resolved. So the patient was discharged. The next 2 days, the news that reached us was that the patient is dead at home because abdominal pain rose up. But then they rushed the patient to a municipal hospital, or let me say a higher level of the hospital. That's a tertiary level at night when the abdominal pain happens. That was the night that the patient died in the hospital. So they rushed the patient for emergency surgery. And when they opened up the patient, they realized that the patient was having intestinal perforations. So the intestine has perforated as a result of intestinal obstruction, you see. So if a patient presents with abdominal pain, don't give first aid. Try to find the root cause of the patient's problem. Is that okay? All right. So let's move on. So there will be pain in the mid-epigastrium. So pain in the mid-epigastrium may be accompanied by abdominal distension. So sometimes, not all the time, sometimes patient pancreatitis may be accompanied with abdominal distension. And then sometimes there will be a little bit epigastric pain. Okay, there will be epigastric. So it is not all the epigastric pain that is ulcer. Bear in mind, it's not all the epigastric pain that is ulcer. Okay. Then sometimes there is a palpable abdominal mass at the epigastric region. A palpable abdominal. So if you palpate the epigastric region of the abdomen, you can feel that there is some mass over there. Sometimes, to some extent, it will feel very tenderness. You feel some tenderness over there. Is that okay? All right. And then also there is decreased peristaltic movement. You know, peristalsis. Peristalsis is the wave-like movement of the GIT. Is that okay? So there will be decreased peristaltic movement, and then vomiting that fails to relieve the pain or nausea. So sometimes or all the times they will be vomiting. Now, if the patient vomits and then the vomitus is yellowish, you should know that the vomitus is coming from the stomach. If the patient vomits and then the vomitus is just like the food that the patient ate, just the food that the patient ate, then you should know that the patient is having ulcer and it's also from the stomach. If the vomitus is, the color of the vomitus is red, then you should know that it is also coming from the stomach, and that there is either inflammation or bleeding in the stomach or in the esophagus. If a patient vomits and then the vomitus looks like a dark red, The other one was bright red, but this one is a dark red. They should know that the vomitus is from the stomach, and then probably the patient started bleeding long time ago, and then the bleeding has been there, so it is old bleeding. And then if a patient vomits and then the vomitus is greenish coloration, you should know that there is problem with either the pancreas or the gallbladder or the liver. Three things involved: the pancreas or the gallbladder or the liver. So you have to know the color of the vomitus and then where it is coming from, or the problem that probably it is happening. All right. Clinical manifestations. So pain is frequently acute in the onset. So sometimes they will only feel the pain after a heavy meal or after the intake of what? Alcohol. Is that okay? And then also, pain may be more severe after meals and it will be unrelieved by antacids. So sometimes you may be mistake pancreatitis to ulcer. You see, sometimes you may be mistaking pancreatitis to what? To ulcer. So pay attention to it. Okay, pay attention to it. All right. And then patient appears acutely ill. So that one, it runs through all disease conditions. And then also there will be abdominal garden. Yesterday I explained what garden is, what abdominal garden is. So if the patient is walking, he will try to either put the palm or the hands at where he or she is feeling the pain, or the patient will try to stoop. Okay, he will try to stoop when walking. So that's the abdominal garden. So rigid or board-like abdominal. So that is the generally an ominous sign, usually indicating peritonitis. So we call it the ominous sign. So whereby the patient will be stooping. Then we have something called the ecchymosis in the flank or around the umbilical region or the umbilicus. So which indicates severe hemorrhagic pancreatitis. So the flank, you know the flank, your lateral side, the flank where your kidney is, you should know your flank. And then nausea and vomiting, there will be nausea, vomiting, fever, jaundice, and all of those. Is that okay? Yeah, so sorry. I am back. So like I was saying, where did we get to? Okay, so we were still on the clinical manifestation. So yes, there will be nausea, there will be vomiting, there will be fever, especially if the pancreatitis or the inflammation is caused by virus or bacteria. Then there will be jaundice. You know, any condition which is affecting the pancreas, the liver, the gallbladder, there will be jaundice. Is that okay? Then there will be what we call mixed edema. That's mental confusion. It's also known as mixed edema. Then there will be agitation. The patient wouldn't feel okay. Then there will be hypotension related to hypovolemic, and then that's hypovolemia and then shock. So there will be hypotension. And then there may be high pulse rate, that is tachycardia. There may be cyanosis, that is bluish coloration of the skin because of hypotension. Is that okay? Then there will be cold, clumsy skin. The patient's skin will be very cold and then clammy. So it's all due to hypotension. That is why the patient may develop all these signs. And then there will be acute renal failure. But for the acute renal failure, it happens if the acute pancreatitis is now graduating into chronic. Then there will be respiratory distress and hypoxia. Hypoxia means that low oxygen level in the tissue. And then there may be diffuse pulmonary infiltration. There may be dyspnea, there may be tachypnea. Dyspnea means that difficulty breathing. Tachypnea, high respiration. There will be abnormal blood gas values. Then there will be myocardial depression. So for the signs and symptoms, there are lots. There will be disseminated intracoagular coagulation. This one, this condition, it mostly happens to pregnant women who are having pancreatitis, and then we will talk about it when we start or the next time we will meet for obs and gyns class. We will talk about conditions or abnormalities in pregnancy. So we will talk about. I'm sure our next meeting, it should be obs and gyns, I'm sure. So be well informed. Assessment and diagnostic findings. So how do you diagnose, or what are the various diagnostic tools that you can request for your patients whom you are suspecting pancreatitis? So you can use the clinical history or the clinical manifestation to diagnose pancreatitis. Sometimes you can use your physical examination or physical findings. And then sometimes you can request for lipase and then amylase level in the serum. That's serum, lipase, and amylase. So if there is increase of serum, lipase, and amylase, you should start suspecting pancreatitis. And then also sometimes, for the sake of infection in the blood, we can request for white blood cell count. In fact, full blood count to know the HB level too. And then for the sake of the presence of hypocalcemia, you have to request for BUE, blood urea electrolyte, so that you can find the electrolyte levels in the blood. And then you can check for creatinine, because we said there will be acute renal failure. And then you also have to be aware that there will be glucose urea. That is, there will be high glucose level in the urine. And then you have to also check for serum bilirubin levels. Is that okay? Because we said there will be jaundice. You can also request for X-ray of the abdomen, but then sometimes we prefer the ultrasound, the abdominal USG. Abdominal USG. So sometimes we prefer that one. Gerontological consideration. This one is pertaining to the elderly patient. So the mortality from acute pancreatitis increases with advancing age. And in fact, it cuts across almost all the disease conditions. The more you grow, the more your cells become weak. Is that okay? And the more you become vulnerable to certain disease conditions, which would have been resolved simply in a younger patient. Incidence of multiple organ failure increases with age. You have to take note of it. And then also close monitoring of major organ function like the lungs and in the kidneys in adult patients. In an adult who is having pancreatitis, you have to take much note, or you have to monitor for complications or damage of the nearby organs, like the lungs, the kidneys, then the liver, and then the heart. Then also aggressive treatment is also necessary to reduce mortality in the elderly patient. So when an elderly patient is presenting with pancreatitis, you have to take note very well because they are already vulnerable to it. And then medical management of pancreatitis. So we have the acute phase. If the patient pancreatitis is in the acute phase, so during the acute phase of pancreatitis, management is symptomatic. When you say symptomatic, you manage the signs and symptoms. So the patient is having fever, you manage the fever. That's in the acute phase. And then directed towards preventing or treating complications. So if the patient is dehydrated, you hydrate. Temperature, if the patient is having hyperthermia, you provide remedies to it. Is that okay? So the acute phase, you have to. Then nasogastric suction is used to relieve nausea and then vomiting. But then mostly we prefer administering antiemetics. Is that okay? To reduce vomiting and then nausea. And then to decrease painful abdominal distension and paralytic ileus. But then we prefer giving the antiemetics, sometimes promethazine, sometimes citropin. And then we have the histamine 2 receptor antagonist. Sometimes we give the cimetidine and the ranitidine. They are all antihistamines. Is that okay? Sometimes they prefer giving the hydrocortisone. Or sometimes they even give the dexamethasone. Sometimes you can give the proton pump inhibitors like the omeprazole and co. So yeah, so sometimes they give it to secrete. For the omeprazole like this, they give it to decrease the HCl secretions. Is that okay? And then adequate pain medication such as morphine is normally administered. Now morphine is actually morphine is preferred to other painkillers like pethidine because for the morphine, you can give it even if the patient is in respiratory distress, you can give it. Or the patient is having cardiac condition, you can still give it. It is safe as compared to the pethidine. Is that okay? As compared to pethidine. So that's why morphine is preferable. All right. And then okay, good. The antiemetic agents are here. You prescribe to prevent vomiting. And then, so it is just like you are just doing symptomatic treatment. Based on the symptoms that the patient is preventing, you treat in the acute phase. So if the patient has lost blood or is having low HB, you know what to do as a nurse. And then if there is infection or if the white blood cell is more than the normal levels, you know what to give. You give antibiotics. If the patient's glucose level is high, you know what to give. Okay. So for the medical management, it's very simple. Then for the nursing management, I won't talk about the nursing management because we are all nurses. Well, let me talk about it. So the nursing management, when you come to pain relieving, you know what to do for your patients. When it comes to pain relieving, you know what exactly to do for your patient. So you administer analgesics as prescribed, and then also you can provide diversional therapy and all those. So you know what to do for your patient to relieve your patient's pain. And then improving breathing pattern, so you know what to do. Is that okay? All right. So for the nursing management, you know exactly what to do. And then you have to assess the nutritional status of the patient. The nutritional status of the patient. So you have to make sure that if the patient can swallow, then that one you would encourage the patient to eat foods low in fat. Is that okay? And then if there is hyperglycemia present, the patient should eat foods low in carbohydrates and then sodium. You have to encourage the intake of protein foods also. You have to monitor serum glucose levels so that, because once the patient is having pancreatitis, he's at a risk of getting hyperglycemia. Is that okay? And then also you have to you have to monitor and then manage potential complications like dehydration. So you know what to do for your patient. The dehydration for the infusions, Renger's lactate is preferable to normal saline. So you have to take notes. Okay. So these are some of the nursing management. And then let's look at the complications um, of pancreatitis. So complications of pancreatitis, we have hypovolemia. Sometimes the acute pancreatitis can lead to chronic pancreatitis due to alcohol use. Sometimes it can lead to a, a surgical complication, which is pancreatitis pseudocyst. So once it has gotten to pancreatitis pseudocyst, the patient has to go for surgery. The patient will go for laparotomy surgery with cystostomy. Yes. Then also the patient is at a risk of getting type 1 diabetes mellitus. Then the patient is at a risk of getting lung effusion or the sudden collapse of the lung. That is atelectasis. Atelectasis means sudden collapse of the lungs. The patient is likely to get coagulation defect like DIC, disseminated intravascular coagulopathy, and all of those. So this is the end of pancreatitis. So we'll take another, today we are not going to keep long. Is that okay? Today we won't keep long. So we are going to take another presentation, and I believe, or I'm hoping it should be our last presentation for today. The next time we will meet, we would actually look at ups and downs. So please inform your friend. This class is free. This class is free, so kindly inform your friends about it so that they can also join and then benefit. So let's take our last presentation. Let me try to save this screenshot. This screen